Recording in progress.
Hi, everyone.
Hello.
Hi. Hi, Dr. Alsati.
Hello, hello.
Hello.
Hi.
Hi. Hi, Mike. Okay. I am sorry it had to be an evening session today. I had too much work, too many slides to finish. So, anyways, all set. We can start. Am I audible very well?
Yeah, I can hear
Yes.
you very well.
Yes.
Oh, okay, perfect. All right. So, stomach tumors, fundic gland polyps, fundic gland polyps. We know about this. Benign, most common stomach polyp. Hyperplastic expansion of the deep oxyntic mucosa with cystically dilated oxyntic glands and foveolar hypoplasia. Parietal cell hyperplasia. Usually asymptomatic and incidental, associated with PPI. Can have beta-catenin mutations, CTNNB1. If numerous, more than 20 in a young patient, consider polyposis syndrome such as FAP. Next is hyperplastic polyps. Benign, second most common cause of gastric polyps. Elongated, tortuous, hyperplastic foveolar epithelium. Cystically dilated glands. Inflammatory changes and edema. Often eroded at surface. Small, haphazardly distributed smooth muscle. Hyperproliferative response to tissue injury. Usually arrives in setting of long-standing gastritis. Precursor is polypoid foveolar hyperplasia and will be hard to differentiate from hamartomatous polyps. Just hold for a second.
I can't hear you now.
No, she said to wait for a second, I think.
Oh, okay.
Yeah, I'm back. Sorry about that. So hard to differentiate from the hamartomatous polyps, so hyperplastic polyps. Pyloric gland adenoma, polypoid proliferation of pyloric gastric glands, cuboidal to columnar cells with foamy ground glass cytoplasm. No well-formed apical mucin cap, often dilated, basal round nuclei. Usually older individuals with atrophic or metaplastic autoimmune gastritis and or H. pylori. Sometimes syndromic, so FAP and GAPP. Activating GNAS and KRAS and inactivating APC mutations can develop high-grade dysplasia to carcinoma, stains with MUC6. Dysplasia. So low-grade foveolar type. So it could be neoplastic change of the gastric epithelium without the stromal invasion can be gastric or foveolar type or intestinal type or mixed. So intestinal type will look like colonic adenoma with tall columnar cells with hyperchromatic nuclei. And gastric foveolar type has tubulovillous or serrated forms lined by cuboidal to columnar cells resembling gastric foveolar cells. Nuclei are round to oval. There is apical neutral mucin. Regardless of the type, graded as high versus low. So low grade dysplasia and high grade dysplasia. Low grade is preserved polarization, that there will be basal nuclei, relatively preserved architecture, and intestinal, there will be hyperchromatic nuclei, elongate cigar-shaped nuclei. Foveolar, there will be round to oval nuclei. Coming to high-grade dysplasia. So high-grade dysplasia, prominent cytologic adipia with enlarged nuclei, high NC ratio, sometimes prominent nucleoli, loss of polarity, complex architecture, indefinite for dysplasia, is not a biological entity, used when there are questions as to if lesion is neoplastic or reactive, often very inflamed. Intermucosal carcinoma, invasion into the lamina propria, characterized by gland crowding, excessive branching, and budding, can see single cell infiltration, trabecular growth, intraglandular necrotic debris, irregular gland fusion. Okay.
I had a question. Dr. Sati, maybe you can answer that. We had a case once where the GI pathologist said at least intramucosal adenocarcinoma, and then I think a few weeks later the patient returned for staging biopsies, and it was all gone. So I feel like it was some sort of inflamed ulcer that looked like adeno, and I think the fact that the biopsy was taken from the ulcer bed had something to do with it. Have you been faced with these kind of situations?
Yes, so the first thing we would do in such cases is we ask for the biopsy. Was it done at the same institute, the prior biopsy?
Yeah.
Okay,
It was at our hospital.
All right. So one, you can go either way in this case. If it was kind of indefinite in an ulcer bed, and it was supposed to be called an indefinite for dysplasia, recommend rebiopsy after inflammation subsides. Probably that would be the best way to go through it. However, it doesn't mean that it might not be an early adenocarcinoma, okay? And in an early stage adenocarcinoma, yes, he could have just taken the whole thing out when he took the first biopsy. So honestly, at this point, no one can tell, and I would just suggest that the patient gets followed up as if he had an early cancer. But for sure, if there was no amassed lesion, no nodularity, and was just a focal ulcer edge, I would definitely have been more cautious in my wording and call it epithelial atypia. See comment. In my comment, I would say this could either be an eroded ulcer bed changes with nuclear atypia. I can't tell at this point whether it's dysplastic versus reactive. I would definitely bring him back in a month or so to rule out through dysplasia. But I'm not surprised if they didn't see anything after that. And so again,
yeah,
my answer to
it
you,
was
could be both ways. It could be an overdiagnosis, or it could be,
right.
yes, a true diagnosis, and they took the whole thing out from the first biopsy.
Yeah, you know how it becomes a big deal when you go to tumor boards and you have to explain how it all went away. And yeah,
Yes.
I think a more cautious approach. Yeah, thank you.
No problem.
I'm muting, there is some background noise. Okay. Yeah, I mean, to me, if it was like dysplasia or / intramucosal carcinoma that was just like in that area of the biopsy and it went away, or you don't see it in the excision, that might happen and not uncommon. So I mean,
Yeah, it was pretty convincing. Like if because I remember, because I presented it, and the first biopsy was pretty convincing for adeno. It looked quite ugly, and we were surprised when the patient came back a few weeks later. There was nothing in the staging biopsies. So yeah.
Right. All right. So intestinal type adenoma, localized polypoid lesion, whereas dysplasia can be flat and multifocal, non-localized with dysplastic intestinalized epithelia. Third most common type of gastric polyp. Any cause of gastric intestinalization is a risk factor. For example, H. pylori, autoimmune gastritis, etc. Look similar to colorectal adenomas and have similar genetics. Rarer polyps, foveolar type adenoma, similar to foveolar dysplasia, but localized polypoid lesion, usually syndrome associated, FAP or GAPP, with no background of inflammation, unlike intestinal type adenomas. Oxyntic gland adenoma, neoplasm composed of columnar cells with chief cell differentiation, pale basophilic cytoplasm, and with mild nuclear atypia mimicking oxyntic glands, high rate of progression to invasive adenocarcinoma. Oxyntic gland adenoma. I haven't seen a case of oxyntic gland adenoma. Have you seen it?
I haven't had. I had a foveolar type adenoma. I did.
Yeah.
I actually, my colleague, not myself, she had a foveolar type adenoma arising in a heterotropia of a duodenum, gastric heterotrophy. And that was really challenging. It went all around for confirmation. Nonetheless, it's not cancer or anything, but the patient needs to be followed up very closely. But no, I haven't had an oxyntic gland adenoma yet. Waiting.
All right. So far, any questions? Any more questions, guys? Malignant tumors, adenocarcinoma, malignant epithelium neoplasm with invasion of lamina propria by neoplastic glandular cells or beyond. Risk factors: H. pylori very strong, chronic infection, chronic inflammation, intestinal metaplasia, dysplasia, carcinoma. Also, smoking, EBV infection, and dietary factors. Morphological types: tubular and Signet ring cell or poorly cohesive. Tubular most common, branching tubules of variable diameter, solid growth with variably recognized tubules is included in this group. Signet ring, second most common, neoplastic cells isolated, arranged without well-formed glands. Signet ring cell is composed predominantly or exclusively of the signet ring cell type cells and are characterized by clear, optically clear, central, globoid droplet cytoplasmic mucin with an eccentric nucleus. Mucinous extracellular mucin pools, and then it should be more than 50% of the tumor in order to call it mucinous carcinoma. Tumor cells may be in glands or may be in single cells. Papillary, relatively rare. Exophytic growth with elongated finger-like processes, lined by cuboidal to columnar epithelium supported by fibrovascular cores. Well differentiated with pushing invasion, but nevertheless has worse prognosis. Gastric adenocarcinoma with lymphoid stroma, also called as lymphoepithelial carcinoma or medullary carcinoma. So syncytial growth of irregular streaks and tubules of polygonal tumor cells with rich lymphocytic infiltrate, EBV associated. Separate subset are MMR deficient. So get EBV and MMR IHC on any case you are considering for this. Hepatoid carcinoma resemble liver. Large polygonal eosinophilic cells may stain with HEPAR1 and or AFP, usually arginase 1 negative. Micropapillary adenocarcinoma, small clusters of tumor cells without fibrovascular cores protruding into the clear spaces. Worse prognosis like micropapillary carcinomas in other organs. Fundic gland type, developed from oxyntic gland adenomas, very rare. Mixed, contain 2 or more types and worse prognosis.
I just have a small comment about the gastric cancers.
Let me, there is some background noise coming. I'm muting everyone. I just muted everyone. Dr. Alfati, I think you were talking.
Yeah,
you can unmute.
Right. Yeah. I wanted you to go back to the signet ring cell morphology. So just an advice for everybody who's going to do GI or who's doing GI. I can't express enough how much it's very, very easy to miss signet rings. And I practiced, I wouldn't say I developed, I just have a mental checklist when I have stomachs, which I basically do stomachs, minimum 60 a day. So when I hold my stomachs, it's very easy for me to miss it. So I go with a checklist. First of all, on low power, I look for inflammation. Like, is this stomach inflamed versus not inflamed? And then, because that will guide me towards H. pylori. Number two is I want to make sure that requisition form says antrum, and I'm looking at an antrum. I don't want to be looking at a body and then it looks antral to me. Then I will have to think about AMAG and so forth. So again, also correlation with the origin. So correlate with the origin, do an inflammatory check with my eyes, and then I go higher. Now I will look at the epithelium. Do I have IM or do I not have IM? After I look for IM, I look at the lamina propria. Do I have anything funny in the lamina propria? Do I have signet ring cells in the lamina propria? Regardless of the history, regardless of anything. Those 4 types of checklist, I move with them every single case. And if I don't do this checklist, believe me, we will miss signet ring cells. And it happened. And it's not something, there's only 2 types of pathologists. Those who missed it and those who will miss it. There's none. So it's very subtle, it's there. So always keep an open mind for that. Very simple example is a case that came across my table today. Patient is 48 and it was a gastric ulcer and it was all signet ring, no surprise. Okay, I'm gonna call it signet ring carcinoma. And he has another biopsy from the antrum and the other biopsy from a GE junction and another biopsy from the duodenum. Everything looks clean. And then on my review again to the GE junction, for some reason I went deeper. I want to make sure there is IM or there's no IM. And there is a lot of signet rings, a lot of them underneath the epithelium, which for the first time I looked at it, I scanned it and I did not see it. So of course that drove me to do a keratin on all my biopsies. And luckily it's only in the ulcer and the GE junction. The antrum and the duodenum are negative, but it's that easy. I mean, it's very, very easy to miss it. Just a little kind of key thing for everyone in the audience.
How frequently do you see?
Did you say that you patient had an ulcer and endoscopy as well?
I can't hear what the question
Priya,
was.
you're getting a lot of background in your.
Yeah, I'm
phone.
driving. That's okay.
Okay.
You can message. You can message
Yeah,
in the.
you
Oh,
can
you're
message the
driving. You
group
can.
when you're in a safe place.
Yeah, yeah.
Mhm.
I was saying, how frequently do you see in your practice signet ring cell?
Oh, signet ring, minimum 6 a month.
6 a month,
Yeah,
and you have a very high, very high volume.
we do. Yeah, we have a very high volume of. Yeah, I read between 150 to 250 blocks a day.
Yeah, yeah,
Yeah,
yeah.
and that's only me. My colleague does the exact same thing. So, we split in half.
Right. Yeah. Yeah. I always fear. It's my biggest fear while looking in the stomach biopsies to miss a signet ring
So,
cell.
Dr. Alsati, do you have that kind of a checklist for all of GI? And if yes, do you mind sharing it with us?
Yeah, well, it's all in my head, but whenever we come across, I will give you one of them is in the duodenum. I know we finished the duodenum, but in the
Yeah, and
checklist of the
he had a
duodenum, I have to rule out giardia. Okay, so if I don't
right.
think about it, I don't see it. That's one thing. In my duodenum, I look through, I look at the location, I look if there's heterotropia, I look if there is increased lymphocytes, I go to the lamina propria, I see if there's any infiltrating disease, and then I look on the surface, on the white area next to the mucosa, and I look for giardia. And again, if I don't think about it, I miss it. The eye does not see what the brain doesn't know. So that's yeah, we think the giardia looks like junk in the background. So our eyes are meant in pathology to just ignore junk, you know. But if you, yeah, you just have to keep an eye, even because especially in giardia, the mucosa and the epithelium is not too inflamed, so it won't trigger you to look for it. So you have to have it in your checklist. Yeah, I have plenty of checklists. I have to go through a checklist, or otherwise I will definitely miss things. But whenever
Yeah,
I
You can
think of
continue.
one, I'll include
You
it.
can continue. We can continue talking about your checklist. That seems very, very interesting.
Okay.
Just you can throughout the GI just continue talking about it. I would
Yeah, yeah.
Okay.
I remember when we were reading yesterday and Dr. Kurt's notes, and there was a small intestine topic which started with his checklist. And today, when I was doing my GI biopsies, my mind automatically navigated to it because we had read it yesterday. And like you said, I found it much easier to go through the biopsies with a checklist in my mind.
Oh, yes. Yes, absolutely.
Do you want to talk about the other checklists here as well, Dr. Alfati?
I can't think about it right now. Once we walk through it, because let's say
Yeah.
let's hold it organ by organ. Now we're doing the stomach. Once we get to the tumors of the esophagus or something, did we do esophageal tumors already?
Yeah, we did yesterday.
We did. Okay, I'm sorry, I can't remember. But yeah, so let's say if we started by esophagus, okay? If you want to take a note of this, esophagus is very interesting because in the esophagus, when you want to do a checklist in your head, I look at the esophagus very different if the esophagus is a GE junction, a distal versus proximal, okay? I will allow few EOs in the distal. I will not allow any EOs in the proximal, okay? So for instance, my checklist is in the esophagus as follows. How deep did he go? Okay, for instance, is it a full thickness or just like a touch from the tip? Because that will make me think of a sloughed esophagus or a patient with the esophageal disease, because the more the esophagus is inflamed and diseased, the more friable it is, and he will not be able to take a whole bite all the way to the deep, okay? So just by looking at the type of the biopsy, I can tell if there is pathology or not. Now, I look for lymphocytes, I look for spongiosis, I look for EOs, and I look for parakeratosis, okay? These 4 things. Where is my mind going? And my mind is trying to make a reflux diagnosis, okay? I wanna make sure that, okay, the patient has GERD, I will probably, this matches the histology, the history. However, let's say he saw a nodule, okay? So in my checklist, if he didn't call a nodule or anything, I will still look for other pathology around the papillae. Do I have sebaceous adenoma? Do I have some sort of increased eosinophils? So my head is kind of thinking outside the box right now. I'm not only at the reflex diagnosis, I want to see if there's anything deeper. And again, for sure, if you don't think about it, you won't see it. You look around the papillae of the esophagus. Do you have any adipose tissue? Do you have any sebaceous glands there? Because it's so easy to miss these things. And then I'm looking at the EOs. Now, do I count EOs? Unfortunately, I do. Okay, just because our clinicians want a count. But I know a lot of people don't count EOs in the esophagus. And I didn't used to count EOs before, but now I have to because the clinicians like it. However, my cutoff for EOs are 15. So if anything under 15, I'll just call it reflux esophagitis at most, 15 eosinophils per high power field. Or if it's above 15, I will say eosinophilic rich esophagitis, and I'll add the comment of it could be reflux or it could be EOs. The amount of EOs in my esophagus varies between the top versus the bottom. I am more aggressive in counting in the top. And the location of the EOs matter. Is it at the surface or at the base? Okay, when it's at the surface, it's pushing me towards a reflux disease. When it's at the base, close to the papillomatosis area, it's pushing me towards an eosinophilic esophagitis. So again, I know I'm going onto tangents here, but you have to have a checklist in your esophagus for parakeratosis. Oh my gosh, I forgot. Whenever I see parakeratosis and active eosinophils, I have to order bug stains for fungus, okay? And I do GMS, I do PAS. A lot of people do GMS. However, it's very important to do that because a small, tiny hyphae, and this is an advice to everyone, they could be so small, they could be so tiny, but there's a lot of candida esophagitis, okay? I know it's surprising. It's actually surprised me when I first practiced. I thought that most of my PASs are negative, but honestly, some of them I actually probably missed. because once I learned how to just carefully work with my PAS, take it surface by surface, level by level, I am surprised, but I do find tiny hyphae at the surface embedded between the active neutrophils. So just keep an eye on your PAS. It's there, and there will be candida without you guys noticing that. So just be careful when you look at your PAS stains or GMS stains. Yeah, that's it for the esophagus. And then the stomachs, I think I went through the stomach. I told you the IM and the Signet ring checklist and the inflammation checklist. And then you move to the duodenum. The duodenum was my hardest organ, and it's still the hardest organ. On my second week of practice, I missed the carcinoid. And luckily, the medical director picked it up. So it was like literally 2 weeks after I graduated my fellowship. I missed the carcinoid, which was at the very, very, very edge, and I missed it. So it gave me a great lesson for my 5 years in practice right now, that a duodenum, I always look for carcinoids, even if the clinician did not call it a polyp. And I am so proud to say that I did pick a carcinoid on a patient who was not called as a polyp. so just because I was thinking about it. So the clinician really saw nothing there. And there was a small carcinoid next to a lymphoid aggregate. So when I look at duodenum, you will look at the mucosa. You will look at so number one, the mucosa, is it flat or is it, you have intact villi? When I'm looking at that, immediately my eye tries to find foveolar metaplasia, because in that same time where I'm looking for flattened villi, I'm looking for foveolar metaplasia. This could be just a case of peptic duodenitis. Okay, so common is common. Okay, I do see probably 10 PDs or peptic duodenitis a day. And then the next one, right after my eye looking at the foveolar epithelium, I'd look for increased intraepithelial lymphocytes. Okay, you will have increased lymphocytes without villus blunting. So that by itself tells me that this could be a differential of early celiac versus inflammation versus drug-induced, versus H. pylori versus drug-induced. And this is the third checklist in my head for duodenum. Then I go to the lamina propria. And the lamina propria, do I have dilated lymphatics? Do I have infiltrative disease? Okay. Do I have heterotropia, which is oxyntic glands in this area? What else do I want to rule out? Do I have lymphoid aggregates? If I have lymphoid aggregates, and then put a big star next to that if you're writing notes, look for carcinoid next to the lymphoid aggregates. They try to hide around the lymphoid aggregates. So this is my my checklist for duodenum, and then I go outside my slide, which is outside my mucosa, to the space and look for giardia. Okay. Now I am done with my the duodenum. Let's go down to terminal ileum. Okay. Terminal ileum is interesting. Terminal ileum is usually done for two reasons. Either for insurance purposes, because the clinician wants to get reimbursed because he did biopsies from the terminal ileum all the way to the rectum. So you will, it's like a proof for the insurance companies that they went to the terminal ileum. So honestly, a lot of the time it is completely normal. The patient doesn't have diarrhea. He was not needing even terminal ileum. However, it's a good practice that every terminal ileum you get, you also do the following. You look at the age. Okay, my terminal ileum is by age. I always keep an eye on the age. If the patient is young, I allow a lot of lymphoid aggregates. I'm fine with that. You know, there is just, it's normal. If the patient is 70 plus, I hate to say it, but I don't want to see a lot of fire patches there. She shouldn't be as inflamed as a younger patient. So I want to keep an eye to see if I'm not missing any lymphomas in the terminal ileum, because a lot of people ignore lymphoid aggregates in terminal ileum and they just call it benign fire patches. But always keep an eye correlate with the age. So I look at the age first. Second of all, I look at the history. Does the patient have diarrhea? Does the patient have Crohn's disease or whatever? And based on that, I start my checklist. My checklist will start with the epithelium, okay? My epithelium is active or not, okay? Neutrophils. The second thing, which I promise you I missed, pyloric metaplasia. Pyloric metaplasia in terminal ileum is a sign of chronic ileitis, of course. The problem with that, it's very subtle, it's very focal, okay? And I usually don't see chronic ileitis without focal activity. I had one few weeks ago and I was so surprised, but the patient was treated. So I didn't have any activity. I just call it chronic ileitis, no activity. And then I did mention that this could just be, you know, coalescent Crohn's disease for that matter. Third thing, so after I look at pyloric metaplasia, I look at active inflammation. Where do I go next? I'm sorry, I am mentally now signing out the case in my head so I can be able to just throw out all the checklist with you guys. Right now, after that, I will go to, okay, yes, very important. I rule out granulomas, okay, very important. And if you find a granuloma in your terminal ileum, you don't right away call it Crohn's. Why? Because the terminal ileum is the #1 place for colonic TB, okay? Although you want to have granulomas in your terminal ileum to call it Crohn's disease, but if you have a granuloma in your terminal ileum, you do AFB, and I had 5 cases in my practice where I have colonic TB through my 5 years of practice, okay? So it's terminal ileal ulcer. They were all labeled as terminal ileum ulcer. And I noticed in Kurt's notes yesterday when we were talking about infection, at the terminal, he did mention that the TB, the commonest site is distal ileal or terminal ileum, okay? So keep that in mind, don't forget it. Be very patient when you're doing the AFB, and you will need to put the timer on and do between 15 to 20 minutes with your Mozart music on the side and take all your time because you will only find 1 bug or 2, okay? It's not loaded. So literally when you have a caseating granuloma terminal ileum, it is TB until proven otherwise. Be very, very, very patient. Okay, next with the terminal ileum, your comment is as follows, okay? You have chronic active ileitis. This may represent, okay, no granuloma, no CMV, blah, blah, blah. This may represent drug-induced injury. This may represent involvement by infectious etiology or IBD. And why do I say IBD? You can favor Crohn's disease if the patient has granuloma. However, IBD, this may represent backwash ileitis versus Crohn's disease, okay? So this is your differential when in a young patient who doesn't have an established diagnosis of Crohn's disease, okay? Otherwise, you can say chronic active ileitis consistent with patient's known history of Crohn's. All right, now we move on from the terminal ileum to the ascending colon, transverse, descending, all of these. I'm not gonna talk about the polyps because it's a completely different topic, but let's talk about non-polypoid areas. My checklist for the colon is as follows. Does the location matter? So once you become a more seasoned GI, I'm not saying that I'm seasoned at all. I'm still very young in my practice, but once you have seen a lot of colons, you can tell the biopsy if it's coming from the rectum versus from the ascending colon. The thickness of the muscularis, the way the glands are shaped, the way you have more EOs in the right side than the left side. So you can kind of tell. So for me, I kind of practice to look at my slides and then look at the requisition form and match the location. However, I check the age. I go with the mucosa. Is it inflamed versus not inflamed? I go with the lamina propria. Do I have plasma cells? If I have plasma cells, is it diffuse? Is it intraepithelial versus is it only in the lamina propria? Now I look at my epithelium. Is it nice looking crypts versus do I have diffuse a crypt architectural distortion? You know what I mean? So the way I'm going with this Do I have active colitis only? Do I have chronic active colitis only? Do I have completely normal colon? Okay, and if I have completely normal colon, where does my eye go? My eye go to the surface, and I look for spiroketosis. Okay, and spiroketosis, if I don't think about it, I will miss it. Very important, because it's something subtle and not all the time you can pick your eyes pick on it. And if you're looking at a biopsy from the rectum, from the descending colon, it's very important for you to look for these things over there. Again, now if I don't have active, I don't have chronic, now I want to rule out microscopic. I look at my collagen thickness, and then I look at the intraepithelial lymphocytes, okay? So these are the checklists. The checklists have to be diagnosis based, okay? I know we want to think about rare things, but common is common, okay? And we see that day in and day out. So my diagnosis should be either no active, no chronic, no microscopic colitis, okay? And then no CMV. These are the things that I need to see in terms of, and I don't only write it there, I look for it, okay? And then I have to pretty much look for dysplasia. And dysplasia is not something that's very difficult to see. It's, it's like almost a tubular adenoma in a flat area, and you want to rule it out. And always keep in the back of their mind, even if they don't see polyp, even if you don't see anything, you rule it out, okay? Just on a low power, scan it and look at it. Yeah, one more thing from the checklist, just be careful. Look at the gross description and look if they say three pieces, 5 pieces. Match that with your slide. It's so easy to miss, okay? Because they're small scattered biopsies. So just keep an eye and always try to, I actually count. I look at the tissue, they said 6 pieces, and I will go 1, 2, 3, 4, 5, 6. Good, I have 6, it matches. Now when I am removing my slide out of the scope, my last thing I do another count. 1, 2, 3, 4, 5, 6. That means I counted my things twice. That means I did not lose a tissue on the side that I missed, okay? Colon, and last thing is the anal biopsies. Common is common, of course, condylomas, hypertrophied anal papillae, infection, herpes. So these are the things that I think about when I put my anal biopsies on the slide. I think about it, I show it around. We don't get a lot of them, but I show it around, and yeah, you don't want to miss things. Again, one thing that people can miss all the time is viral inclusions. So keep it in the back of the mind. Add this to the checklist when you're doing anals. If I remembered anything, I know I don't want to take from your time, guys. If I remembered anything, I will definitely mention it throughout. But sorry if I was taking a long time.
This
No,
was
thank you.
fantastic.
That was really
This
helpful.
was really, really, really good. This was really fantastic. I would rather have you talk than read anything. I'm telling you.
I did
but
have.
I am here. I do enjoy GI, but I'm here. I'll give you a lot of advice. And please, guys, if you have something for me, let me know, because I also want to learn from you guys. It's not something I probably know very little in GI, so I always would like to enlighten myself with anything, with any of your experiences as well.
So, Dr. Al-Sati, thank you so much. That was really, really good. I just had a quick question about your esophagus checklist. So I just wanted to ask about basal hyperplasia, like in isolation, in the absence of other pathologies, like do you comment on it? What is your criteria? And do you signify, like what pathology does it signify?
Yes, so basal cell hyperplasia, location. If it is at the GE junction or distal esophagus, it's likely a reflux finding. But if it was more distal, I will look for spongiosis, okay? So it's not only basal cell hyperplasia, you wanna see if there is a little bit, some spongiosis in the background, which for the most part, 95% of the time you will find it, okay? Now, if you have basal cell hyperplasia, you have spongiosis, and you do not have EOs, okay? You'll be descriptive. Because usually when you have basal cell hyperplasia and some papillomatosis, and spongiosis, that esophageal background is almost telling you that, you know what, I might be going towards an eosinophilic esophagitis finding, but I could also be a severe reflux change, okay? So look carefully in this patient. If you have a lower in this patient, okay? If you have a lower in this patient, make sure he doesn't have an IBD. Because sometimes people with IBD, they will have spongiosis and basal cell hyperplasia in the esophagus. All right, so and who was talking? Nupur?
Yeah, that was me.
Yeah.
Yeah.
So Nupur, I would also ask you, do you see lymphocytes during those basal cell hyperplasia? Because that will also make a huge difference. If you have lymphocytes with the basal cell hyperplasia, okay, this is called lymphocytic pattern of esophagitis. And this is a diagnosis that not a lot of people use, but also I don't want you to take it lightly. My comment in lymphocytic type esophagitis is it's as follows. Fragments of esophageal squamous mucosa with some basal cell hyperplasia, as well as scattered lymphocytes, see comment. And in my comment, I would say, this pattern of inflammation is non-specific. It could just be a reaction to some severe reflux change, okay? However, this is also seen in patients with IBD, such as Crohn's disease. Clinical correlation is recommended. So what I did two things at this point. I told the clinician, number one, that your patient might have severe reflux. Number two, do a lower on him, because if he has some light diarrhea, you're probably telling him or asking him to keep an eye on this patient. He might develop IBD, okay? But again, I'm not committing, but these are things that are seen in patients with IBD. I hope that was helpful.
Right. Yeah, no, that addressed my exact query. Thank you so much.
Okay.
Hi, I have one more question. Although you said that the polyps discussion you are not doing at this point, but still I have one question related to that. May I ask?
Sure, of course, sure. If
Okay.
Akansha is okay with this.
Oh yeah, please go ahead.
Thank you. So the question is, like in GI biopsies, more commonly like a lower GI biopsies, if the clinician is looking some bumpy lesion and he calls it as a lipoma and he biopsies it, and then in microscopic examination, we are not seeing anything in the sections. That means I know that usually the GI biopsies are GI lipomas are submucosal location, and then these are not, the biopsies are more superficial. In that case, how do you address the problem, or you have any suggestions in regards to commenting this part? Hi. Hello?
Yeah. Oh, so hello. Instead of unmuting myself, I muted myself.
Sure.
Okay, so Lakshmi, I wanted to let you know that I probably have 3 times a week the same problem of calling it a polyp and I have nothing, and calling it a lipoma and I have nothing. What is the most important thing in the if he called it a lipoma and you don't find anything? Number one, lipomas of the colon, if they were mucosal in origin, so if they are in the mucosa or the lamina propria, not in the submucosa, those are more towards a syndromic lipomas. So you have very importantly want to mention the location, okay? Most of the time they are submucosal. Now let's say we have a submucosa and we don't have a lipoma, okay? I go deeper twice in my biopsy, and I go deeper, and I will call this fragments of polypoid colonic mucosa, comma, no significant submucosa. And then I will say multiple deeper levels examined, see comment. In the comment section, I say the endoscopic impression of a possible, I say possible, open quote, lipoma, close quote, seen on endoscopy is noted. The biopsy is superficial. There is no significant submucosa present. No lipomatous lesion seen in this sampling. If open quote, lipoma remains of concern, recommend a rebiopsy. And why am I quoting the lipoma? Because I don't want to miss a carcinoid. okay? Because to the eye of the clinician, a lipoma and a carcinoid are both submucosal bumps. I don't want him to feel like he thinks it's a lipoma. However, if he went deeper, then it is going to be a carcinoid, okay? Always keep carcinoid in the back of the mind. It will look the same for the clinician as the lipoma. Of course, the lipoma, it will have the pillow sign, it will be pushy, it will be less hard, but early carcinoids are also not hard. Okay, I hope that answers the question.
Yes, thank you so much. It was
No
good.
problem. Yeah. Anyone else have any questions? Please do ask.
Hi, Dr. Al-Sadi. I have a question.
Sure.
Today we had a case like there was a large 2.5 centimeter polyp, but they just did a superficial biopsy of it and they sent multiple fragments. So in that fragments, we had kind of serrated polyp in one of the fragments, and there were 2 fragments which had the adenoma, tubular adenoma. So what kind of like collision polyp should we sign it out as? Like, I had this question.
Okay, so where are the location of the polyp? And
It was in the transverse colon.
so transverse colon, you have multiple fragments. Some of them are serrated and some of them are TA, correct?
TA, yeah. Yeah.
Okay, so the serrated
None of them.
fragments, does it look like an SSA to you?
Well, I ordered deepers and it was not okay for an SSA. It was still like a serrated.
Okay, and the tubular adenoma fragments, do they look like tubulovillus to you?
No, it was adenoma only.
Okay, so I would probably, if it does not look like a sessile serrated adenoma, okay,
Mhm.
I will ignore the serrated one because tubular adenomas will have some edge of serration. I would ignore that. So for me, I will say that superficial fragments of tubular adenoma, see comment. And then in the comment section, this is only a biopsy and may not be representative of the entire polyp. Based on the size of the polyp, recommend complete removal of the polyp. Okay, so I do add recommendations in my reports. I don't let it go like that. And also, the reason I said this may not be representative of the entire polyp, because if the patient came back, he might decide that the patient will tell you, oh, it's just a tubular adenoma, I'll wait. And if he waited for another year, what if he already has high-grade dysplasia there? So I mentioned in my report that it is a large polyp. It is only a biopsy from it. It might not be representative of the entire polyp, and I recommend complete removal because it's a 2.5. Okay, so this way, if somebody comes back, if the patient has distant metastasis in 2 years, he will look back at my report and he will say, you know what? That pathologist did say that we have to take it out. That pathologist did say that this might not be representative of the entire lesion. I know, I'm sorry, I'm talking about wording in the report, but you will be surprised that when you start practicing, all it matters is this paper with the ink on it. It's just how you word it and how does the clinician, you know, receive the diagnosis from you. In my opinion, you know what? Shahita, I sometimes take my phone and I call these clinicians. I tell them, hey, how's it going? Blah, blah, blah. This polyp is too big. I know some clinicians they ignore. I know from my practice, I know some clinicians they ignore. And I make a point, I give them a call. You know what? I think that I don't like these cells. It's not high grade yet, but I don't think these cells, I can't call it high grade, but I'd rather you bring the patient back. And this way, I covered my bases. I don't care what the clinician thinks about me. I care at the end of the day what the patient has to have done to him properly. Okay?
Oh yeah, thank you.
You're welcome.
Thank you very much, Dr. Al-Sadi. That was awesome, beyond awesome. Does anyone else wants to ask any questions that they have in their usual practice?
I have a quick question. Has anyone seen a hepatoid adenocarcinoma of the gastric, of the stomach? I think the PIP slides had one at some point. Well, maybe 7 years ago or something. But yeah, I'm curious. I haven't seen one in my practice.
Yeah, I haven't seen as well.
Okay, let's move on.
But I am no GI pathologist. All right. Okay, my kid wants me to whisper, which is not gonna happen. Let me change my location. Can I go up?
Sure.
How old is he?
He's 7-year-old.
There's some leftover cake.
You can
Okay.
have leftover cake.
No, I'd like to get back to meditating.
He's meditating down there. Wow,
Mm.
7-year-old. All right, sorry about that, guys. All right, so wanna start again? Okay, let me on the lights here. So where were we? We did this hepatoid.
We finished this funding gland type, yeah.
So we're in the molecular now. All right. Chromosomally unstable, predominantly intestinal type morphology with extensive DNA copy number. Just give me a second, guys, okay? Sorry about that. Okay, I'm all set here. So molecular subtypes. First is chromosomally unstable, genomic unstable, MSI, and EP positive. Okay. So chromosomally unstable, predominantly intestinal type morphology with extensive DNA copy number variations. Frequent TP53 mutations, most common subtype. I don't know why I'm so breathless. I think I'm having some asthma. Nupur, do you want to read for some time?
Yeah, sure, I can read.
Yeah, please go ahead.
So molecular subtypes: chromosomally unstable, genomically unstable, MSI, and EBV positive. So chromosomally unstable is predominantly intestinal type morphology with extensive DNA copy number variations. You often have TP53 mutations, and this is the most common subtype. For genomically stable, you have predominantly the diffuse signet ring morphology, obviously fewer genetic alterations, and you may have CDH1 and RHOA alterations or mutations. For MSI, mutations or promoter methylation of mismatch repair enzymes, often MLH1, and we know that MSI high has a better prognosis. Then EBV positive, usually histologically gastric carcinoma with lymphoid stroma, PIK3CA and ARID1A mutations, and often PDL1 is amplified. Prognosis is better. Okay, staging. Akanksha, can you scroll? Tumors with an epicenter within 2 centimeters of the GE junction should be staged as esophageal cancers. All tumors in the stomach that do not cross the GE junction or have an epicenter in the stomach more than 2 centimeters from the GE junction should be staged as gastric. So in situ, high-grade dysplasia is in situ. T1A invades lamina propria or muscularis mucosae, 1B submucosa, T2 muscularis propria, T3 subserosa, 4A perforates the serosa, and 4B is adjacent structures. Then biomarkers.
Say something here really quick. If you go back to the staging, yeah. So very important when you put your diagnostic line, if you have an adenocarcinoma at the GE junction, or let's see, they called it GE junction, but you only have a pure adenocarcinoma, no squamous epithelium, or you know what I mean. So my diagnostic line will always say adenocarcinoma, comma, diffuse type or moderately differentiated or poorly differentiated or whatever. I don't call it squamoglandular junction mucosa with adenocarcinoma. I don't call it esophageal adenocarcinoma. I don't call it gastric adenocarcinoma. It's up to the clinician to make that decision, because adeno is adeno to me. It's whether it's in the esophagus or in the stomach, okay? And I don't want to label the patient with gastric adenocarcinoma metastasizing to the esophagus as esophageal adenocarcinoma. Okay, so very important to use proper terms when you put in your diagnostic lines, because the clinician is the one who picked the biopsy, and he is the one who knows where he picked it from, the location, whether it's 2 centimeters above, 2 centimeters below, whatever. So just be very cautious when it's just a word of advice.
Right, thank you. Yeah, that Z-line question is always there, right? Predictive biomarkers, anti-HER2 therapy is used in patients with unresectable or metastatic tumors, and we'll see the guide for the grading scheme. EBV and MSI, tumors that are EBV positive or MSI higher, better prognosis. He already said that. Okay, well-differentiated neuroendocrine tumors or NETs, proliferation of cells with round nuclei, salt and pepper or speckled chromatin, and abundant eosinophilic cytoplasm, arranged in nests, acini, trabeculae, and ribbons. They express neuroendocrine markers, that is synaptochromo and INSUM1, 3 main clinical settings or types. Type 1, associated with autoimmune gastritis, where you have destruction of parietal cells, decreased stomach acid, compensatory hyperplasia of the antral G cells to try to signal to make more acid, and then they secrete gastrin. There's ECL cell hyperplasia and net formation. Type 2 is the one with Zollinger-Ellison syndrome with a duodenal or a pancreatic gastrin-secreting neuroendocrine tumor, which stimulates ECL cell hyperplasia and stomach net formation. Type 3 is sporadic, and it's higher stage and more aggressive. Size requirements. This can vary a little by source, but generally, neuroendocrine cell hyperplasia is collection of greater than 5 NE cells. It can be linear, chain, or micronodular, which is clusters. Less than 0.15 mm. Okay. Dysplasia is nodules greater than 0.15 mm, and fused nodules or infiltrative nodules, which is in situ. Micronet, cellular proliferation filling the lamina propria, the nodule greater than 0.15 but less than 0.5. And then net, we know, is more than 0.5 mm or invasion into the submucosa. So, so do you give this, I mean, like Dr. Alsati, do you use this 0.15 criteria and this is how you report it?
Oh my gosh, this is a very challenging topic in our field, because when we do a chromogram or synaptophysin on these, basically I already have it because of the MAG. I know the patient has history of MAG. That's the most common ECL cell hyperplasia I get. I become very descriptive, because remember, we are looking at small biopsies and you have scattered ECL cells grouping, okay? So if the nodule I am looking at does not measure up to 5 millimeters, it's a 0.5 millimeter, then I'll just call it maximum, let's say maximum 4 millimeters in thickness. But and then my comment will say this is not accurate, and this is just a small biopsy. And if you have a bigger lesion, please go ahead and biopsy it. Do an ultrasound of the patient, because he is more prone to have a net tumor. So yes, I do measure it all the time. I try to screen all my areas. I try to get the largest measurement of the nodules I have. And remember that it has to be a continuous measurement. You can't have normal epithelium in between them. Okay, so if you have a nodule here and a nodule here, and they're intermixed with normal epithelium, this breaks the measurement. Okay, it has to be a continuous proliferation of endocrine tumor or endocrine cells that measures up to 0.5 millimeters. Okay.
Yeah, yeah, thank you. That's helpful.
I have one question related to this. So these measurements are usually for the stomach, correct? And what about the colon? Do we have the same numbers there in colon biopsies, also neuroendocrine tumors, colorectal?
No, we don't have the same. Remember, in stomach, the reason we have that grading scheme is because we have patients with AMAG, and they might live for the longest time in their lives with micro nets. okay, with very, very, very small, and it might not even ever progress to carcinoids, to true carcinoids. In the
Sure.
colon, you don't have that precursor. In the colon, you're not even supposed to have these cells. There is no ECLs there. There is no to start with. So it's always a dysplastic, a neoplastic process in the colon, okay?
Okay, thank you.
Okay. So grading, we know Ki67 proliferation index based on the evaluation of 500 cells or more in a hotspot. The mitotic count is based on evaluating 50 hyper fields, but is reported per 10 hyper fields. And grade 1, 2, 3 less than 3 for Ki67, mitotic index less than 2. For grade 2, it's 3 to 20% and 2 to 20 for the mitosis. Grade 3 is more than 20% and more than 20. Okay, so here's a table depending on, like he had classified type 1, type 2, and type 3, depending on their etiology. Do you want to go over this?
Me?
Okay. I mean, no, I was just asking the audience, but sure, we can just do it.
Okay, I thought you were talking to me. Okay.
You probably already know it, but it's okay. Autoimmune gastritis, like we discussed for type 1, it's multifocal and their ECL is the cell of origin. It's most common. So type 1 is 85% of the gastric nets. You do see hypergastrinemia. We remember that, that there was increased gastrin production. And then ECL cell proliferation is there. Acid secretion is low, which is why the autoimmune gastritis happens in the first place. Then background mucosa has atrophic gastritis. Stage at diagnosis is usually low. Endoscopic mucosal resection is the treatment. 5-year survival close to 100%. Type 2 Zollinger-Ellison syndrome, often with MEN1. Multifocal ECL is the cell of origin. It's not very common, 5%. Hypergastrinemia, ECL cell proliferation are present. Acid secretion is high. Background mucosa shows parietal cell hyperplasia. Stage at diagnosis is low. 5-year survival is 75%. Type 3 is sporadic, unifocal. Cell of origin, DG, ECL, and EC cells. 10% of gastric nets. No hypergastrinemia, no ECL cell proliferation. Acid secretion normal. Background mucosa normal. Stage at diagnosis is often advanced, and 5-year survival is less than 50%. So have you seen the type 3 one? I'm guessing if everything looks normal in the background, then it's just your finding of those neuroendocrine cells that you're relying on, right?
Absolutely, absolutely. And also you have, again, this is the same thing. Part of your checklist in the stomachs is, again, when I'm telling you, look at the lamina propria and look at the submucosa, it is to look for tumors. One of them is Signet ring cells. The other one is actually subtle carcinoids. So,
Right.
and by the way, just a piece of advice, when you have lymphoid aggregates, just take a scan around these lymphoid aggregates. You'll be surprised of how much you can find around these things. And there's plenty of lymphoid aggregates in the stomach sometimes when there's H. pylori and so forth. But when there is no H. pylori and nothing else, why would the lymphoid aggregate be there? Okay, it's probably trying to fight some sort of a foreign thing that came through. So it's an alarming sign to the eye of a pathologist all the time.
Yeah. I think just one thing that I also wanted to run by you is I've seen my attendings, like you said, if there's a focal lymphoid aggregate and you're like, maybe there's a carcinoid hiding somewhere and you still can't find it, they'll comment on the fact that there was a focal lymphoid aggregate just to sensitize the clinician, I guess.
Yeah, it's for two reasons. Let's say we're talking about a polyp and it's a prominent lymphoid aggregate and we're doing deepers and levels. We want to rule out other things, but also for the clinician, well, okay, that might explain the bump that he saw. You know what I mean?
Yeah.
But except in the duodenum, I never mentioned lymphoid aggregates in the duodenum because I don't want to fool the clinician that he did his due diligence. If he saw a polyp and I saw a lymphoid aggregate, I wouldn't call it that this is a good sample because I would rather him go back and make sure he takes better biopsies because duodenum you can miss a lot. Okay, so I wouldn't call a lymphoid aggregate in the duodenum unless, of course, it's exuberant, huge 2-centimeter lymphoid aggregate or whatever.
Right. Thank you. Okay. Hold on one second. Okay, so neuroendocrine carcinoma, they often arise from non-neuroendocrine tumors and subsequently develop neuroendocrine differentiation, sheet-like growth, not graded, Ki67 or mitotic index greater than 20% and is often much higher, malignant, very metabolically active and rapidly growing, see on normal PET scans. Molecular P53 and RB1 and other carcinoma-associated mutations. Treatment is platinum-containing chemotherapy. Then we have small cell neuroendocrine carcinoma, morphology, fusiform nuclei, finely granular chromatin, scant cytoplasm, nuclear molding, extensive necrosis, tons of mitosis, and Ki67, 100%. So the classic small cell. Then large cell neuroendocrine carcinoma, morphology, large round nuclei with prominent nucleoli and moderate amounts of cytoplasm, sheet-like to nested growth, and Ki67 often in the 60 to 80% range. Okay, then we can do other malignancies. Oh, this is our favorite part, heme. Lymphoma, the GIT is the most common site of extranodal lymphomas, and the stomach is most commonly involved site. The two most common are DLBCL and extranodal marginal zone lymphoma. So DLBCL, diffuse infiltrate of atypical large lymphoid cells that show immunoreactivity to B cell markers, CD20, PAX5, 19, 79A, and are negative for EBV. Most cells resemble centroblasts. They tend to localize to one anatomical site and are less aggressive than their nodal counterparts. However, like nodal disease, we must still do full workup to classify as terminal center or activated B cell and look for the MYC and BCL2 alterations. Then extranodal marginal zone or MALT lymphoma, often associated with H. pylori infection, diffuse to perifollicular infiltrate of small centrocyte like two monocytoid lymphocytes, positive for B cell markers, 20 and PAX5, 43 and MNDA1, negative for mantle cell markers, CD5, SOX11, cyclin D1, CLL, CD523 and LEF1, and follicular lymphoma, CD10, BCL6, indolent course and often cured by eradication of H. pylori. Okay, squamous cell carcinoma, carcinoma with exclusively squamous differentiation with keratinocyte-like cells and intercellular bridges and or keratinization, very rare. Adenosquamous carcinoma, carcinoma with both glandular and squamous differentiation, with each at least 25%. Undifferentiated carcinoma, carcinoma composed of anaplastic cells without histologic or immunophenotypic evidence of differentiation. Diffuse malignant cells, often patchy keratin. It's a diagnosis of exclusion. You must rule out lymphoma, melanoma, EBV-associated gastric carcinoma. Okay, gastroblastoma, often young men, biphasic tumor of the gastric muscularis propria with spindle cells and nests of epithelial cells. MALAT1 and GLI1 gene fusion. Okay, never seen or heard of this one. Okay, I think we're done with this one. So if anybody has any questions or comments.
Has anyone seen a gastroblastoma?
I haven't.
Yeah, I haven't, as Nupur said, I haven't heard of it.
I think like considering they say it's nest of spindle cells, maybe we thought it was GIST and it wasn't.
They haven't covered, like, I should not say that, but Kurt hasn't covered the polyps as they should have been. He has like discussed adenoma and traditional serrated adenoma, fused triggers, juvenile prolapse. I mean, it's not bad too, but I felt like polyps needed more than this. But let's read. I can read now. So okay. Colon polyps, adenoma, picket fence nuclei, elongated, pencilated, pseudostratified, hyperchromatic. Nuclei retain basal orientation, bottom half of the cell. Low-grade dysplastic changes should involve at least upper half of the crypts and the luminal surface. Now, will lead to high-grade dysplasia eventually, or carcinoma in situ. Significant cytologic pleomorphism. And rounded, heaped up cells, high NC ratio. Nuclei open chromatin, prominent nucleoli, loose basal orientation, extend to luminal half of the cell. Okay. So then you have the tubular, tubulovillous, and villous adenomas. More than 75 tubules in tubular, 25 to 75 in tubulovillous, and less than 25% tubules in the villous. And similarly, villi, villous, so less than 25% villi in the tubular, 25 to 75 in the tubulovillous, and more than 75 to call it villous. Intramucosal carcinoma. So, all right, over here, so high-grade dysplasia, we read this much. Architectural complexity, cribriforming, solid nests, intraluminal necrosis, absence of definitive breach of basement membrane. Okay. If there is a breach, then you go for intramucosal carcinoma. So neoplastic cells through basement membrane into the lamina propria, but not into the muscularis mucosa. Single cell infiltration, small and irregular angulated tubules, marked expansion of back-to-back cribriform glands. No metastatic risk, paucity of lymphocytes in the colonic mucosa. Now coming to the invasion into the submucosa, that will be implied by a desmoplastic response. Chromosomal instability pathway, most common. So APC, then KRAS, then P53, and also often beta-catenin and SMAD4. Lynch microsatellite instability pathway, there will be germline MMR, loss of heterozygosity, and MSI. Coming to serrated polyps. So first is hyperplastic polyp, superficial mucosal outgrowth characterized by elongated crypts lined by non-dysplastic epithelium with surface papillary enfoldings. Serrated luminal contours, like a knife. Then sessile serrated lesion, also called as SSP or SSA. Usually large, so they will be more than 1 centimeter. They will be sessile and right-sided. Architectural disturbances at the bases of the crypts is required. Serrations extending to bases, asymmetrical growth, and then boot-shaped or duck-foot. Only more than 1 or equal to 1 unequivocal distorted crypt is required. So only 1 is enough. Size of polyp, so 1 to 5 millimeter. They will be in the left colon and right colon. So right colon, irrespectively of the size, like vast majority, or there will be at least SSA, mix of SSA and NHP. In 6 to 9, vast majority SSA, and obviously more than 10, essentially all SSA. In the left colon, think of more of HP. So 1 to 5, vast majority HP. 6 to 9, if they are getting big, then think of mix of SSA. And 10 or plus, the vast majority will become SSA, even if a polyp is more than 10 in the left colon. So sporadic, go ahead.
Just wanted to tell you something. You have to memorize this table, okay? It's going, if you are ending up in GI, this is how you're gonna live. 5 millimeter and 10 millimeter. The 5 millimeter and below, it could be HP, it could be SSA in the right colon. Anything above 5 millimeter with some serration, I blindly call it HP, okay? I don't even sweat on it. And a lot of people may disagree, but I don't. So I would rather have the patient come back rather than not. But it does not mean that you cannot see HPs in the right colon. Okay. So my diagnostic line will be serrated if it's less than 5 millimeters, serrated polyp with features consistent with HP. Okay. I wouldn't write it all HP blindly, because I'm giving the doctor the option. If he wants to bring the patient back earlier, I'm fine with that. Okay? Like the insurance will tell you, oh no, she's calling it HP. Why are you bringing the patient back in 3 years? Oh, well, I feel like it because I don't want to miss it. He's so young. But if I said serrated polyp, it's consistent with HP, then the insurance will say, you know what, she has the word serration there. She might hint that why not bringing the patient again? See what I mean? Like a lot of small details in your diagnostic reports that will affect patients coming back or not. And it will give the doctor a little bit more flexibility in terms of, you know, well, he wants to send the patient for another 10 years. Yeah, that's fine. Send him for another 10 years. But if you want to bring him back in 5 years, I'm okay, fine with that too. Okay, so it's up to the clinician, especially on the right side. On the left side, I am much more loose. I really have to have very deep living crypts at the bottom. Very important, the checklist with serrated adenomas is as follows. I look at the base and I look at the muscularis. Before I do anything, do I have the base of the crypt wider than the top? Okay, if it's wider than the top, then my priority is an SSA. All right, if it is narrower than the top, then my priority is an HP. Okay, and then I will look at the location and then I will look at the size. So I blindly make a diagnosis on my H&E before I look at the paperwork. I kind of draw the diagnosis first before I look at the paperwork, and then I look at the paperwork and then, but that's my style, but you don't have to do that. It's just like it keeps you, it keeps your way of looking at the slides always fresh. Like it's good to go blind to the slide.
So this might be a silly question, Dr. Al-Sadi, but what if you don't have muscularis? If it's a superficial biopsy, then how do you write it?
Hi, okay. So if you are at the right side column, you will say superficial. Of course, you have to go deeper. Before you rule out no muscularis, you have to go deeper because it might still be in your block, okay? So you will say superficial fragments of serrated polyp based on the size now. If the size is more than 5, favor sessile serrated adenoma. If the size is less than 5, then I will say with features suggestive of a hyperplastic polyp. Okay?
Okay.
But you don't have a muscularis, look for a muscularis. It's very rare. I honestly very rare saw that I don't have muscularis. For the most part, we get it, you know?
Okay, thank you.
Very, very interesting discussion. Very important. All right. Anyone else has any questions? Okay. Then coming to traditional serrated adenoma. Serrated adenomatous polyp, uncommon. Prominent frilly serrations of the glands. Columnar cells with mucin depleted eosinophilic cytoplasm. Cytologic low-grade dysplasia throughout. Complex architecture with ectopic crypt formation. Often pedunculated, villous, and left-sided. Can contain a KRAS mutation derived from goblet cell-rich hyperplastic polyp, or BRAF mutation derived from microvesicular hyperplastic or SSL. Okay. Coming to Peutz-Jeghers. So these are hematomas, non-neoplastic, germline mutation of STK11 or LKB1, most frequent in the small intestine, multilobated, may have papillary or frond-like surface, arborizing smooth muscle, generally cytologically bland epithelium, mucocutaneous melanotic macules or lips or oral mucosa, increased risk of many cancers, including stomach, colon, pancreas, breast, etc. Coming to juvenile polyps, common in children, but may occur in any age, usually smoothly spherical, pedunculated polyp, prominent cystically dilated glands, abundant inflamed stroma, surface may be eroded. Dysplasia or carcinoma are very rare in the sporadic polyps. If more than 4 or 5 polyps or extra colorectal location may indicate juvenile polyposis syndrome.
I just want to make sure to tell you something. For those, if you can go back, yeah. For the juvenile polyp, I do see it in adults, okay? And it's always puzzled me that, oh my God, I mean, I'm not gonna call this a juvenile polyp in this 70-year-old guy, okay? So after I read so much about it, so the adult version of it is retention type polyp, okay? So it's the mucosa is kind of, it retains, it's edematous, it's inflamed, and it becomes a little bit cystically dilated. It might be next to a diverticulum. So these are basically almost, they look exactly identical to juvenile polyp, okay? But in adults, and I just want to throw this in, it's also called retention type polyp. Don't sweat on it. If you have a juvenile in an adult, just call it retention type and move on. No significance, and don't be lost in the books. And it happens, and that's it.
Thank you. Okay. Prolapse polyp. Changes may be seen secondary to rectal mucosal prolapse, often anterior rectal wall within 12 centimeter of the anal verge, superficial ulceration or erosion of the mucosa, thickened disorganized muscularis mucosa with extension into the lamina propria. Smooth muscle will surround the individual crypt. Regenerating mucosal epithelium may appear adenomatous, distorted crypts, sometimes diamond-shaped crypts. Okay. Follow-up guidelines, these are important. So starting at age 50, next follow-up if there is no polyp or normal in next
Now
10 years.
45.
Now 45, okay.
Yeah.
40. Adenomas, 1 to 2 tubular adenoma. If it is less than 1 centimeter, then come in 7 to 10 years. 3 to 4, if less than 1 centimeter, come in 3 to 5 years. 5 to 10, less than 1 centimeter, come in 3 years. More than 10, come in 1 year. More than 1 TA, that is more than 1 centimeter, again 3 years. Villus or tubulovillus is 3 years. Adenoma high-grade dysplasia is 3 years. Piecemeal resection of adenoma of more than 2 centimeter, then come back in 6 months. That's an important point. Serrated polyps now. So less than 20 hyperplastic polyps, less than 1 centimeter, 10 years. If there are 1 to 2 sessile serrated, less than 1 centimeter, then 5 to 10 years. 3 to 4 sessile serrated, less than 1 centimeter is 3 to 5 years. 5 to 10, less than 1 centimeter is 3 years. Any sessile serrated more than 1 centimeter, again 3 years. With dysplasia, 3 years. Hyperplastic, which is more than 1 centimeter, 3 to 5 years. TSA, 3 years. Piecemeal resection of the SSP more than 2 centimeter is again 6 months. So we have to, that's important if we have to mention about the piecemeal resection. How do you handle that? How do you handle telling?
Yeah, it's a very challenging one. So the doctor will say, so what's important about the piecemeal resection? Nothing other than we don't have a margin, okay? So the clinician was not able to remove this, whatever, 3 centimeter polyp as in a single snare. So he takes bites and bites and bites and bites. He knows from the beginning that I will not be able to comment on the margin, okay? However, if I have a single piece with an intact margin and a nice stalk, and which is inked and it's negative, then my diagnostic line will say margin negative for dysplasia. And sometimes I will say the deep margin versus the mucosal margin, because sometimes the deep margin of where the muscle is, that's negative, but the mucosal margin, when the epithelium is still on the side of it, I still have some low-grade dysplasia. So I would say deep margin negative for high-grade dysplasia, mucosal margin so show focal low-grade changes, okay? And so it's very important about having it in one piece. The piecemeal, the entire purpose of it, they're telling you piecemeal resection, regardless of the pathology of what the pathologist is telling you, bring the patient back in 6 months, because they know that the pathologist could not tell where the margin is, okay? Because you took it in 6 pieces. Okay, which piece is close to the base, which piece is close to the surface? I can't tell. All right. So so that's why you have 6 months. So I would say let's say sessile serrated adenoma, comma in fragments, and then I might or I might not. And usually if there's high grade, I will say focal high grade dysplasia and a sessile serrated adenoma came in fragments. In the comment, and I would say margin cannot be assessed due to fragmented nature of the biopsy. Okay,
Yeah.
so I do mention that. And this is very clear for the clinician, so he can bring him back in 6 months.
Right. Yeah. All right. Anything that I like, if anyone wants to take from this is I mean, so in my residency, all the attendings, they taught me to write if there is a multiple polyps, then write multiple polyps. But in my practice, one of my senior persons, he told me, if you see 3 polyps, they said 3 polyps, then write 3 polyps, because it's going to change their management. So that's what I have started doing. If I see 3 polyps of tubular adenoma, I would rate 3 fragments of tubular adenoma. And I don't know how you handle it, but that's what I have started doing.
Yes, Akansha, for sure, for sure, for sure. I always count. I always count my polyps, and numbers are very important for the clinician and for the follow-up.
Right. And what do you do, like in some instances, one of the fragments does not have any changes, 2 fragments have tubular adenoma, how do you handle that?
So let's say there's many scenarios we can go from here, but let's say if the clinician said 3 polyps and I have 3 adenomas, that's simple. I'll say TA times 3, okay?
Yeah.
Let's say if we are 3 polyps, 1 is lymphoid aggregate and 2 are adenomas, I'll say TA times 2 and then a separate fragment with a small lymphoid aggregate. And then let's say 2 are TA, 1 is HP, I will say 2 TAs, 1 HP. And then let's say 2 normal, 1 TA, I'll say 1 TA and 2 fragments with no significant histopathologic changes, multiple deeper levels examined, okay? If I have a normal, I will do a level, okay? Just because I want to make sure there's no deeper in my slide, in my block. Now, I completely ignore it if the patient has already 20 TAs, okay? I wouldn't like sweat on one focus that it has no problems in it. It's only when it is 3 or less than 3. That's where I actually become very serious. Or actually 1 HP and the other one has nothing in it. Oh, well, he might end up having a TA, which will bring him back in 10 years. Yeah, so something like that.
Got you. Anyone else have any other questions? Polyps is this is a bread and butter, and you might have a lot of questions.
Yeah, adding to that discussion, what we do is if, like, let us say that they are telling 5 polyps and we are getting 7 fragments. So we are not going to have the matching of this same thing, whatever they have seen. So we will just mention it as multiple fragments and we can leave it like that. Or we are also saying that how many fragments with adenomatous change and how many fragments with normal colonic mucosa.
Got you. Where do you practice, Lakshmi? Do you practice or are you in fellowship residency?
No, I am in practice and I'm in Houston, Texas.
Houston, very nice. Okay. All right. So that's the last flow chart that they have. High quality colonoscopy, complete to cecum, adequate bowel prep to detect polyps more than 5 mm, adequate colonoscopist adenoma detection rate, complete polyp resection, risk stratified repeat colonoscopy intervals. So 10 years, 7 to 10 years, 5 to 10 years, 3 to 5, 3 and 1. So in 1 year, if more than 10 adenomas, 3 years, 5 to 10 adenomas, 5 to 10 SSPs, adenomas or SSPs of more than 1 centimeter, adenomas with villus or tubulovillus histology, high-grade dysplasia, SSP with dysplasia, and TSA. 3 to 5, so 3 is the cutoff. 3 to 4 adenomas, less than 1 centimeter, or 3 to 4 SSP, less than 1 centimeter. Any hyperplastic polyp more than 1 centimeter will be 3 to 5 years. 5 to 10 is 1 to 2, so then 1 to 2 SSP is important. And then 1 to 2 adenoma, 7 to 10, and less than 10, 20 hyperplastic polyp, less than 1 centimeter is 10 years. All right, so that concludes our polyps. Now tell me, how does it look for other people? Do you want to
Time
continue?
check. Just
Yes.
Yeah, just time check because it's 8 p.m.
Yeah, that's what I'm saying. How does it look like for other people? Are you fed? Are your kids fed?
I would say let's resume tomorrow, but that's just me.
Yeah, me too.
What about other guys?
My son is coming
Okay.
in 5 minutes. I have to.
All right, then perfect timing. All right, if anyone has
Okay,
any questions,
thank
we
you so
can
much.
we can consider that. Otherwise, we can just go. Anyone has any questions? All right then. Okay, thank you very
What's
much, Dr.
tomorrow?
Alsati.
Thanks,
What's
Akanksha.
tomorrow and what time?
So we are going to have starting colon cancer,
Okay.
and tomorrow is a little bit weird for me because tomorrow is kind of very irregular schedule that I have here.
Okay.
I will have to see by 12 p.m. Is it okay if I let you guys know by 12 p.m.?
Yes, I'm fine with
Okay.
that. Well, it's going to be 3 my time, which is fine.
Yeah. Yes. 12 p.m. will be 9 your time. 9 a.m.
9 a.m. Oh, perfect.
Perfect. Okay. So I will let you know by 12 p.m. as to how my day looks like, and then we can decide as well. And tomorrow is Friday. I mean, in the evening, people might have plans. I don't know. So let's see if possible. We are going to take the 4 to 5:30
Okay.
itself. So that will be 1 p.m. your time.
Okay, sounds good.
All right.
Have a
Okay.
good
Thank
night,
you very
everyone.
much.
Take care.
Thank you
Yeah.
very
Bye
much.
bye. Yeah. Thank you. Bye bye.